Hello and welcome to our conversation today about Camizestrant in the treatment of patients with metastatic HR-positive, HER2-negative breast cancer. I'm Hope Rugo, a breast medical oncologist at the City of Hope Comprehensive Cancer Center, where I lead the Women's Cancers Program and the Division of Breast Medical Oncology. And I'm joined for this conversation by my colleague and friend, Dr. Becky Shatsky. Becky, thanks for being here.
Thanks, Dr. Rugo. My name is Becky Shatsky, and I am the Director of Breast Medical Oncology at the University of California, San Diego. And I'm excited to talk today about oral SERDs.
Great. Yes, and I know we are talking about management of patients all the time and how we're making decisions about sequencing, which I think is really the big question for us in terms of the oral SERDs and how we're going to best apply this data to the metastatic setting. Of course, we have data in the early stage setting and a number of ongoing trials evaluating oral SERDs in the early stage setting, including Camizestrant, the subject of our discussion today, both upfront with CDK4/6 inhibitors and with switching in the high-risk adjuvant setting. So we're going to see a lot of data with this, and I think our patients are really hopeful that these will all be positive trials so we can move the new endocrine therapies into the early stage setting. But right now we have new endocrine therapies in the metastatic setting. We have 2 approved treatments by themselves for ESR1 mutant disease, and we know that ESR1 mutations develop under the pressure of treatment and are subclonal as opposed to the clonal mutation we're used to seeing. PIK3CA, PI3 kinase targeted agents are used, but this is something where we see the mutation pretty much throughout the course of breast cancer with rare acquisition of new mutations. But ESR1 mutation is really an acquired mutation.
Yep.
So the question I have for you to start with is, how do you think about that in your clinical practice, and when do you measure?
Yeah, so I actually like the story of ESR1 mutations a lot because it makes a lot of sense to me as a resistance mutation that develops in response to the sort of evolutionary pressure that you're putting on the cancer. And cancer is trying to survive, it's trying to evade the treatment that we're giving it. And that actually reminds me back, my training before all of this was as in microbiology. And so I always think of the sort of parallels between bacteria developing drug resistance and hormone-positive HER2-negative breast cancer developing endocrine resistance through ESR1 mutations, specifically resistance to aromatase inhibitors.
Yeah, I think I also think it's quite intriguing. And the data that came up comparing fulvestrant to exemestane, where we were able to look at ctDNA eventually and ESR1 mutations and show that the fulvestrant worked much better than the aromatase inhibitor has been fascinating. And then the trials showing that fulvestrant itself is not the optimal treatment for patients with ESR1 mutations, and that there's a subgroup that have no response, have really resistance up front.
Yeah.
We had I worked on one of the first iterations of the ASCO guidelines for metastatic HR-positive breast cancer with hormone therapy. It was a very specific guideline. And, we said, yeah, sure, you can check for ESR1, but it's not going to change what you do. And things have completely turned around 180 degrees since that original guideline where we didn't have these oral SERDs, but we do now. So when a patient has disease that is they're on their first-line therapy. We now have data from SERENA-6 that these ESR1 mutations emerge somewhere around in the second year, mid-second year, later second year, and that changing therapy can prolong disease control where you keep the CDK4/6 inhibitor the same, but you change the oral SERD. And that trial looked at changing from an AI to the oral SERD Camizestrant. How do you think about that when you're thinking about how you're going to manage your patients? Are you going to be measuring the appearance of ESR1 mutations and, having a longer progression-free survival and a dramatic maintenance of quality of life compared to continuing on the AI? How do we put that into our clinical framework?
Yeah. So the hormone-positive, HER2-negative breast cancer space is a crowded and confusing arena right now, I would say. And I can understand why people are just completely confounded by all of the different options. Like you said, there are patients who develop these ESR1 mutations, specifically the Y537S, that it confers resistance to fulvestrant. And so if you look at sort of the first trial, or one of the first trials where we looked at maintaining that CDK4/6 inhibitor backbone, the MAINTAIN trial, which is a phase 2 by Dr. Kalinsky, we saw that some patients, just by switching the backbone and whatnot, could do well. Now, this is switching to a more effective backbone. However, the trial is novel in that what we have done for all of breast cancer is wait till a metastatic patient has visible progression on scans to switch therapies. And that has really been ingrained in us forever, that that is the best thing for the patient. However, what you just mentioned about maintaining the quality of life here is really intriguing, because the oral SERDs in general are quite well tolerated. Camizestrant, alicestrant, imlunestrant, all of them are, compared to, some of our other targeted medicines. And this in its own right is a targeted medicine, I suppose. We're restricting these to ESR1 mutated cancers. And so the idea of being able to maintain an oral regimen that is well tolerated and more effective is really, really kind of exciting. The parts that are still unknown, I would say, is how frequently, when, uh, uh, we should look for the development of an ESR1 mutation. And if that happens, in this trial, they randomized, but they switched therapies and gave those patients that developed the mutation camizestrant.
And continued the same CDK4/6 inhibitor and
Yeah.
still got an improvement from 9 to 16 months in PFS, which is interesting. But I do think that quality of life fall off, which, was primarily due to pain and to some degree fatigue, where, the data shown last year at ESMO, where there was really a big difference between the time to deterioration
Yeah.
in these domains between the patients who stayed on their AI or switched to camizestrant. And that's huge, because our goal is to help people live as long as possible with the best quality of life.
Yeah.
And so that we don't have survival data for this strategy yet, and may not, because it's a complex area, as we have talked about many times. Maintaining the quality of life is a key issue for a longer period of time. You could stay on longer also, which I think is really helpful. And you bring up a really important point about the scans, that scans are not all that helpful in many patients with HR-positive disease. SERENA-6 looked at patients who were on their endocrine therapy for at least 6 months. So endocrine-sensitive disease, where we see bone lesions and it's so difficult to tell progression in bone
Yeah.
for most patients who stay on treatment. So, how would that, you have the emergence of an ESR1 mutation. At San Antonio, we saw that switching resulted in this very rapid and quite good clearance of ESR1, whereas, of course, not switching didn't. Does that impact something about your understanding of disease burden?
Yeah, I would say that it's hard to know how to interpret that at the moment, because we don't have a wealth of data to tell us the significance exactly of what it means that when we, sort of clear the mutation from the ctDNA, it's not the most promising, not the most prevalent mutation that is circulating at that time. But it certainly is really, really intriguing. And, you know, I I am starting to change my thinking specifically about the pain that you mentioned, because, like you say, it's the idea of preventing additional bone lesions potentially is really, exciting, because that does lead to some more disability and pain and decreased quality of life.
Need, yeah.
Yeah, exactly. And, fractures. And so the idea of being able to prevent that, as opposed to what I've been taught in my whole career about waiting as long as possible, is entering my mind and starting to sort of percolate maybe my thinking about metastatic breast cancer. Maybe we're at a place that changing our paradigms is appropriate because our drugs are better and we have more of them. Things used to be so limited in what we had at all that the idea of just, even if there was a bit of progression, staying on because it wasn't clinically
Right, you would
significant.
just, little progression, wait,
Yeah.
and I think that's not lost because, 40% of ESR1 mutations, 60% will not. So we
Mhm.
still are taking that approach until we have more effective therapies there. But we also saw some interesting data at San Antonio about the delayed time to chemotherapy.
Yeah.
And how does that impact you? I mean, it's interesting because once a patient has true progression on the first line therapy, so they've gone past the SERENA-6 time point, and they have an ESR1 mutation, sometimes treatment can be complicated, as we've talked about before, where patients might not want to go onto fulvestrant or an oral SERD alone, and there may be a tendency to reach for the ADC.
Yeah. I That was actually quite meaningful to me because the the time to chemotherapy, that transition for a hormone positive metastatic breast cancer patient is really significant. I mean, we know this when we treat breast cancer day in and day out, that going from the ability to travel and not be tied to an infusion center and to have, preserve your hair as a patient with metastatic breast cancer is really so important. And then that transition, especially when we're talking jumping to an ADC, where they're tied to the infusion center, their quality of life drops dramatically because of nausea, hair loss, risks. That's a big thing. So delaying that onset to chemotherapy is a meaningful endpoint for me, actually. Like, because I really think in this specific disease too, quality of life is i- absolutely essential because we have the ability with our medications as opposed to, triple negative breast cancer where everything is ADC
Right.
or chemo. We have the ability to maintain quality of life for much longer in this disease. And so I think that there is a really important push that we should try to do that.
Yeah, I agree with you 100%. And I think, the disability from ongoing pain and need to taking pain medications
Yeah.
and narcotics and those side effects, there's just a really tragic when we get these patients who come in who've had delayed diagnosis of
Oh.
metastatic disease and they're so miserable. I saw, we actually both saw a patient where
Mhm.
it's been a really challenging time. And then, the patients have pain and they don't want to take the pain medicine and then
Yeah.
the pain, so if we can really try and avoid that where we've caught the patients earlier,
Yeah.
when their disease is starting to change by a molecular marker of resistance, which is so interesting, the ESR1, this non-static marker, that develops over time and goes away with the treatment with an oral SERD, as we saw in SERENA-6 with these ctDNA dynamics. There's also, I think a lot of people have used ctDNA as opposed to tumor markers now. That's being used as well. Um, do you use that approach ever?
So, I am cautiously examining it, I would say. So, I'm part of a clinical trial where we're looking at, a specific patient population, the lobular breast cancer patient population, which is about 15% of breast cancers, that truly identifying their disease on scans can be almost impossible sometimes because it infiltrates the tissue and it is, some of the lesions are more blastic and less lytic and very, very difficult to evaluate disease by scans. And so in that patient population, I'm part of a clinical trial that is examining the best way to evaluate patients, whether it's quantitative ctDNA or scans or tumor markers or both. Right now, I'm kind of using each one as an additional piece of evidence to help me evaluate the patient. And so I do use tumor markers. In certain patients, have been looking at quantitative ctDNA. Now, I don't have enough evidence right now or knowledge that that is truly the best way. I'm waiting for more data to support that idea, but I'm getting more comfortable with looking at all these data points to help me make the best decision for the patient in front of me.
Yeah, and it may be that in the future we have a planned collaboration, European collaboration, looking at ctDNA to motivate scans, So would you do scans as opposed to our kind of ridiculous every 3 or 4 months or 6 months, depending on if you're an HMO, that which doesn't make a lot of sense.
Yeah.
Or with symptoms that you would instead use rising ctDNA to motivate a scan, and then you would switch, right? Because it probably will be the case that if you switch to an oral SERD, that you'll have better disease control than if you don't switch early.
Yeah.
And that trial will have a crossover design in it also for the
Yeah.
patients who didn't switch, who then develop disease progression will cross over. So I think there's a lot of interesting questions to ask as we go forward with thinking about this in our, we're just at the crux of starting to use this in our clinical practice. So assuming that Camizestrant is approved based on the data from SERENA-6, and we're of course waiting for other trials as well to report with Camizestrant and other oral SERDs, how will you apply that data to your practice? Do you know?
Yeah, a really good question. I'm, you know, I have a feeling, so I do tend to be an early adopter of new approaches. And, even thinking of the Neil Love podcast that we did together with Dr. Bedard, the idea that potentially I could prevent more pain and disability is really appealing to me. And that time delay to chemotherapy is important. I am a high utilizer of ctDNA already as far as making decisions for my patients. I think I want to know all the time, do they have an ESR1? Do they have a PI3 kinase? Do they have an RB1 mutation conferring resistance to CDK4/6 inhibitors? All of these, to me, I like to see the full spectrum of the mutational profile already to help me make the best decisions for therapy. Even is there a somatic BRCA mutation or BRCA pathway? And so I can see it be an easy addition, just adding the quantitative ctDNA to what I'm already doing. I like the idea of it using that potentially instead of scans as well. I mean, so much scanxiety, all of that is real in patients. They waiting for the scans to be read. I mean,
And then inflammation,
Yeah.
little nodes that are from inflammation, things like that.
stress it causes where a patient has a 4 millimeter pulmonary nodule suddenly of, what could that be? I mean, all of it is it's very, very difficult for patients.
Yeah, absolutely. So when would you start checking? If you were to institute this tomorrow, when would you start checking
Yeah.
ESR1 mutation?
Yeah, it's funny you ask that because I'm such a high utilizer that, like, if a patient had been on a aromatase inhibitor previously, even if it wasn't in the past 12 months, I do tend to check, at baseline for ESR1 mutations
Yeah,
because I
but
never want to be utilizing a therapy that the patient is resistant to. And so I would rather know immediately. So if there's any exposure to a aromatase inhibitor in the past, I do check their ctDNA because I like to check that at diagnosis of metastatic disease. And so it wouldn't just be after 6 months on an aromatase inhibitor for me. And then right now, I've been thinking about the patient's symptoms and their tumor markers and their labs and thinking, using that to help me decide when to order ctDNA. But who knows, in the future, maybe I'll use a ctDNA to determine, the reverse if the quantitative measures are going up.
right, I think that's the issue because when you get your next generation sequencing, you don't get the quantitative value.
Exactly.
So right now there are two separate tests. So that's why the real question is when would you send to look for mutations? And so if you forget the first line part that you already did, when would you start doing it as a repeating test? Would you, or would you just do it at a certain point because the patient had pain or something else?
Yeah. So in the SERENA-6 trial, they measured it every 2 to 3 months. I That is a little more frequent. I am concerned about costs. We don't know the insurance coverage of all of this. In the United States, that's an issue. Of course, in European countries, not so much if it is accepted. And so I haven't really figured out how frequently I would utilize this as far as what I do every 3 months, or is in certain patients 6 months okay because they're doing so well.
and have a metastatic disease or something. Yeah.
So,
I think, there probably will be. I will have to individualize to some
yeah,
degree.
that tends to be my practice in general, is individualizing based on the patient in front of me.
And then, the one of the ideas is that, the same kind of thing that's been done with triple negative disease has been done with HR positive disease, where you get, 70 to 18% of patients who don't go on to each subsequent line of treatment
Yeah.
at all, actually, which is amazing. But also there are patients who go on to chemo or ADCs in the second line setting. So do you think that I think it's a question about if there's a delayed time to chemotherapy, could we, by treating before there's true endocrine resistance, just the ESR1 mutation, so by changing earlier, could we delay that time?
Yeah, yeah, and a lot of that, I think, really depends on that disease biology. Those ones that are gonna get that ADC in the second line setting are either your endocrine refractory patients or just really nasty disease biology in the luminal B setting, for example, that you're really worried because the patient has a really big liver burden, or,
Yes.
so those are the ones that you can lose super easily. But I am intrigued, and I like the idea of sort of delaying that potential disease explosion too. There is a patient population too where when you start to get this expansion of the mutational profile, their disease really, they get the liver mets.
Yeah.
And then once that happens, that becomes the focus of everything that we're doing. And so if I can delay the onset of very serious visceral disease, with medicines that provide a good quality of life, that is certainly desirable, in my opinion.
Yeah, absolutely. And we might be able to. I think we're going to have to, in the real world setting, look at patients like that to see if we can potentially change the rapidity of development of endocrine resistance. It makes sense, though, that if you change the treatment and you're not leaving it under the same pressure, then maybe you would get less of additional resistance mechanisms. I'd say it's hard. We know these oral SERDs are very well tolerated. There's not a big concerns about toxicity issues, and you get to avoid the injections of fulvestrant.
Yes,
Which
and
is
that's
really nice.
really, really
A huge
important.
issue. But, uh, you know, there has been some reservations about doing regular testing like this, anxiety, how you're going to deal with this, lots of issues. So, are there questions that you've dealt with when people have talked to you about the study or how you'll apply it?
Yeah, I do think that the psychologic impact is kind of interesting, because in the trial you see this improvement in quality of life. But I would say the patients on trial did self-select to be on a trial where they want to, potentially switch therapies. But in the patient who really doesn't want, because there's a population of patients in breast cancer who does not want to be reminded in any way that they have metastatic breast cancer, and they kind of want to be left alone as much as humanly possible. So the idea of sort of medicalizing them earlier is a little bit tough. I certainly have patients who don't want to come in for more blood draws.
Right.
And so I do think about the impact of that patient population. In the really motivated patient population like this represented, I think they would be thrilled to have these more blood draws. Just like in the curative intent setting, patients seem to want these tests. Um, I also wonder sometimes about overinterpreting these results. Like, the control group here did get additional time out of their aromatase inhibitor. And, there is a limited amount, even though we have way more than we used to, there is a limited amount of therapies that exist. And our patients are living a long time. But if I'm not maximizing the amount of time on each therapy, am I doing the patient a disservice? That still hangs in a little bit in the back of my mind. But then I'm trying to balance that with, hey, they didn't get like 10 more bone metastasis.
And the quality of life
Yeah.
data that came out of
Yeah,
Serena
so
6, yeah.
I still have some questions, and I'm really looking forward as the data evolves in this setting. Follow up from Serena 6, follow up from the other oral SERD trials in a similar setting, to see.
Although this is the unique trial in
Yeah,
this way.
there's no other one that was
No
designed
other
like
study.
this.
And I guess one of the questions is, where do you see this future? I mean, to me, it's fascinating, the idea of picking up a resistance, a molecular marker of resistance that you could tailor treatment for the patient. And as you pointed out, nothing we do is for everybody, right?
Yeah.
So I think try HER2 targeted therapies. Okay, that's for everybody.
That's for everybody,
But,
yeah.
almost everyone. But I think that, in this situation, we do have to individualize a little bit unless we see eventually a big survival differences. But, where somebody who had oligometastatic disease, you might not be doing this quite as early or as frequently, et cetera. But do you see, maybe in the future we'll have patients who have these, high risk early stage cancers, and we'll be monitoring unless we're giving them all oral SERDs up front. I suppose that will depend.
Yeah, that's the other question is are we going to move oral SERDs to the first line setting? And I think there's trials ongoing to answer that as well. Or in the curative setting, what do we do if they have been on these in the curative setting? And, is that exclusionary as far as the metastatic setting? So that's another unanswered question that we have about a lot of our targeted therapies now, CDK4/6 inhibitors included.
Yeah, because you see the you see the ESR1 mutation kind of go way down. I mean, huge decreases in SERENA-6. Does it come back again, if you're not treating a patient? So what happens when those patients develop recurrent disease? That's, of course, way far off in the future. And I think how we combine these agents, a big question with SERENA-6 for me is, should we be changing the CDK4/6 inhibitor, or, the combinations of these oral SERDs with other targeted agents? I mean, imagine if you could give the oral SERD and a drug that targeted the PIK3CA mutations or the PIK3CA AKT-PTEN pathway, even everolimus, maybe this would offer some benefits for patients who didn't stay on their CDK4/6 inhibitor for a long time.
Yeah.
So a lot of exciting areas coming up. And I think that I like the quality of life emphasis in SERENA-6, although obviously the PFS benefit is where the regulatory decisions come about.
Yeah.
But it's an exciting time, and really great to talk to you about this changing area that will benefit our patients, I think.
Yeah, it's a really exciting time in breast cancer. I feel very lucky to be part of this because it does feel like, we're on the precipice of this sort of big paradigm shift, and we have all of these new drugs coming in, and where to sequence them is sort of the biggest problem instead of just having something that works. And so that's pretty exciting to me.
Yeah, it is. It's great to talk to you. Thank you.
Thanks.